or osiredection otherwise. Plan combined surgeries whenever possible, a phaco trab or a phaco bit whenever it's required. Let the patient not undergo multiple surgical trauma. So preoperatively, plan well, counsel the patients well, assess the eye completely, and be ready with all the instruments, but be prepared for all the surprises. Because UAT cataracts can definitely throw up a lot of surprises. As I say, well planned is half done, but be prepared for everything. The actual surgery. Preoperative preparation is most important, and actual surgery is not something that you need to leave it off, because there are major challenges in the pupil management, in the capsule management, and in the intraocular lens decision. There are from small things you need to be worried about so many things. So whether you need to do
not is one question that you need to answer.
PAS, whether you need to release or not is one question that you need to answer.
If it is not strongly adherent, then you can go ahead with it.
Fine.
But beware of DM detachment in these patients.
Go ahead with it. But beware of DM detachment in these patients.
So this is one patient where there was PAS and we tried to remove it.
So this is one patient where there was PAS and we tried to remove it off because
hooks. And
we needed pupil to be enlarged with hooks,
and
it needed
but you need to balance with other
risks, view issues. But you need to balance with other risks like glaucoma and otherwise. As I say, small is never enough, make it large.
Small is never enough, make it large.
I meant always pupil size in cataract surgery. Thing else, ego never.
Pupil size in cataract surgery.
You can manage a small pupil and you go ahead with cataract surgery.
There is no ego here.
It's better to have a adequately sized and retained pupil.
So how do you go about
this?
Pupil management can be by many means. You can have a simple lysis, like in this patient. It's a total cataract. Which may not resolve with anti-inflammatory or medical therapy. You sometimes need a drainage. Vitreous hemorrhage is one thing where long-standing vitreous hemorrhage you need to have VR intervention. If you have a vitreomacular traction, then causing macular elevation, then you need surgical intervention. So surgery for cataract, or surgery for glaucoma, or surgery for vitreoretina needs to be managed preoperatively very well. Intraoperative management, there are specific things which you need to do. But if surgery is over, is it all over? As I say, it's not over till it's over, or it's not over until the Lord says it's over. The biggest challenge is the post-operative management. You need to monitor the inflammation and intraocular pressure. Cystoid macular edema can be a cause, can be aggravated. You can have cystoid macular edema even in normal patients after cataract surgery. And in uveitic, you didn't ask, it may be much more higher. So you need to have a systemic immunosuppressive therapy or some kind of anti-inflammatory therapy for a minimum of 4 to 6 weeks, depending upon the disease and the type of cataract. And also it depends upon the handling during surgery. If it's a dilated pupil, then you don't need to be worried about much. But if you handle too much during surgery, then it's important. Additional antivirals, anti-tuberculous and anti-toxo, you need to give accordingly. Post-operative management is as important. Post-operatively, your patient can develop hypopyon. You need to be able to differentiate between the hypopyon related to the post-operative uveitic entity or infection. Hypopyon, anywhere you always think of infection first, but in uveitic entities you remember that they can have an organized fibrin post-operatively which can mimic hypopyon. Hyphema, they can have, IOP can be high post-surgery. They can have a pigment dispersion in the anterior chamber that can also cause related complications. You can have a PC plaque, you can have a bag that is dehisced, or if it is retinal surgeries, you can have redetachment or vitreous hemorrhage. And after all this, the depressing part is that the patient can still go into optic atrophy. So all other complications, you have some way of management here. A cystoid macular edema, there are multiple options of management. Complicated cataract you can manage, RD you can manage. But once the patient goes into optic atrophy, that's the depressing part of a uveitic thing. So there are few entities where whatever you do, ultimately they may go into optic atrophy. At least you can delay the thing. the patient, you can still maintain the central vision with some amount of field loss. Commonly, optic atrophy can occur after post-viral entities, especially after progressive outer retinal necrosis. They can have a posterior pole herpetic retinitis, which can occlude the vessels. PORN, ARN and Behçet's are two diseases where they can have both arteries and veins involved. So that is the reason they go into optic atrophy much earlier. You also can have optic atrophy after CMV retinitis. Other occlusive vasculopathies progressively, like after post SLE, can be one cause of optic atrophy. So when you look at the complications uveitis, it can be either anterior or posterior segment complications. It can be either due to the disease and or the drugs used in the treatment of the ocular and or the systemic conditions. Patients can develop eye related conditions because of the systemic treatment they take. Something like anti-tuberculous therapy can also have complications in the eye. The medical and surgical, the management can be medical and or surgical. So it's very important that you have an early identification and treatment. The visual rehabilitation depends on that and prevents irreversible ocular morbidity. So uveitic cataracts, as I said, need special attention. It's not just another cataract surgery. Inflammation free period is a must. It's very important to have adequate perioperative steroid cover, at least for 2 to 3 months inflammation free period, followed by about a month ideally. We start about 3 to 4 days before surgery systemic steroids, suboptimal dose of about 0.75 mg per kg body weight. Pupil and capsular management is a crucial part of any complicated cataract surgery management. So phacoemulsification with in the bag hydrophobic acrylic is the best. And post-op follow-up, it doesn't end with the surgery alone. Post-op follow-up and continuous management of the uveitic entity is the long-term goal. There are some complications like BSK, glaucoma and VR. They need to be managed by the specialists. It's very important that you have a team that works on these. Weigh the pros and cons, risk-benefit ratio versus the treatment of the complications. Sometimes the treatment shouldn't be so much that